Thank you so much for inviting me over today, and it really gives me pleasure to talk on one of the most very interesting topic and very dear to my heart. We have a large series of patients with genital Koch, which we have treated in the past 15 years of active practice. And here we're going to talk about how genital tuberculosis affects infertility and how we should go about diagnosing this condition and treating these patients, because a very high degree of index of suspicion needs to be practiced to in order to diagnose this condition on time and also for its early treatment. So TB was recognized as early as 1000 BC. It's a very old disease. Morgagni, in his postmortem of a woman in 1744, a 20-year-old woman found her uterus filled with caseous material. The word TB was coined in 1834, and Robert Koch discovered the bacilli in 1884 very famously. We belong to a high burden country for tuberculosis. India is the highest TB burden country, accounting for almost 1/5 of the global incidence. And like diabetes, India, unfortunately, is also the TB capital of the world. According to WHO, 1/3 of the population is infected with tuberculosis, which can be of any region, any organ of the body, but only 10% of them actually develop active mycobacterium tuberculosis, which is actually a good thing. With an global annual incidence of 9.4 million, India has an annual incidence of 1.96 million cases. As we are all aware that genital Koch is extrapulmonary tuberculosis, it is a secondary manifestation of primary tuberculosis, which is usually in the lungs, and the primary focus heals up. And it's only in 5 to 13% of pulmonary Koch patients develop actually genital Koch. The genital tract becomes vulnerable after puberty, and if the bacilla is not eradicated, then it remains there as latent tuberculosis and later gets reactivated, especially later in life when there is low immunity, like seen in Hodgkin's lymphoma, HIV, when the patient is on steroids, stress, malnutrition, or in all these cases, the latent tuberculosis can become active tuberculosis. Symptomatology, as you're all aware, that a high index of suspicion needs to be kept in mind when you're dealing with genital Koch, because many a times it is asymptomatic. And other symptoms like systemic symptoms like low-grade fever or evening rise of temperature, weakness, these are some of the systemic symptoms of tuberculosis. And since we are dealing with infertility, as an infertility specialist, infertility is actually one of the main symptoms that the patient presents in patients with genital Koch. Other symptoms like menstrual disturbance, which can be oligomenorrhea, amenorrhea in later stages, and even metromenorrhagia is also seen in tuberculosis. Abdominal swelling and formation of adnexal happens when there is formation of adnexal masses, which happens only in advanced tuberculosis. Postcoital bleeding, if there is a cervical involvement, vaginal discharge, which with a very peculiar smell, and even dyspareunia are some of the symptoms of genital Koch. I included this slide of an X-ray chest to tell you that actually when you see genital Koch, your X-ray chest normally of a patient is normally normal, because the primary focus heals up by the time the tuberculosis is detected in the uterus. But fibrocavitary lesions, especially seen in the upper and the posterior lung segments, are very much suggestive of tuberculosis, of pulmonary tuberculosis. Now let's come to the dilemma of how to diagnose. There is a lot of confusion on this, and I thought this presentation will clarify some of your doubts which you have been having about how to go about diagnosing this condition. So first is the definitive diagnosis. If you can see the bug, which is by smear microscopy, or you can grow the bug on solid culture or liquid culture, or you multiply the bug, which is the latest which includes nucleic acid amplification test or NAT. So we are going to discuss each test in detail today. So ZN staining has been there for a very long time for detecting tuberculosis, but it requires very high number of bacilli to show as a positive result. So its detection rate is only 10%. It requires 10 to the power of 4 to 10 to the power of 6 bacilli, 10,000 bacilli per ml to show as a positive result. And the WHO recommends that in order to improve the detection rate by ZN staining, you can improve the microscope, you can use a fluorescent staining, or you can use lead microscopy to improve the detection rate by almost 5 to 10%. But if you can see the bacilli, acid-fast bacilli on microscopy, it is definitely a definitive test for tuberculosis. The next test is TB endometrium and its histopathology. It appears as non-caseating granulomas in the endometrium. As we are all aware that genital Koch affects the tubes, but in 650 to 70% of the cases, actually, it's the endometrium also which gets infected. But since the endometrium is shed every month, you can miss these tubercles because by the time they form, actually it's a new endometrium is formed and the old one is shed. So you really have to look through all your curatings to see just 1 or 2 foci of tuberculosis, and they can be scanty, scattered, and the main cells that you see are the Langerhans cells, the multinucleated giant cells, macrophages, and epithelioid cells. Then there is a best time to do the biopsy. The biopsy should be done in the luteal phase when these granulomas are evident in the endometrium, or within 12 hours of the onset of menses. So if you are taking a biopsy after the periods have already started, then you might miss the histopathology completely. And if you find granulomas on histopathology, it is 100% confirmed that this patient has genital Koch. The third definitive test is culture, which is actually the gold standard, because if you can multiply the bug, then it is absolutely confirmed that this is tuberculosis. And along with culture, you can do the drug susceptibility testing and the genotyping at the same time. It requires around 10 to 100 bacilli per ml. And we have 2 kinds of culture, the old ones, the solid-based culture, which is the egg-based media, Lowenstein-Jensen media, the LJ media, but that requires almost 6 to 8 weeks. Almost the report will not come before 4 weeks. So you have to wait for a long time before your report comes as confirmatory. So to improve the sensitivity of the testing, the liquid-based culture media were introduced. They are agar-based. They give the results in almost 2 to 3 weeks. The BACTEC, MGIT 960 and modified Middlebrooks are the liquid-based media which are usually used. So BACTEC has a higher sensitivity than the LJ media and a better negative predictive value, though the LJ media, which is an older solid media, is highly specific with a higher positive predictive value. Now let's come to the molecular test, which includes a nucleic acid amplification test. And what they do is they search for the genetic information on the test sample, and usually the test sample is the endometrial biopsy, to find the presence of the DNA or RNA of Mycobacterium tuberculosis. The DNA test analyzes the dead bacilli, and the RNA test actually sees the live bacilli. And the best part about nucleic acid amplification test is it's very rapid. Within 48 to 72 hours, you have the report, and you have the rifampicin drug resistance as well at the same time. There are different types of PCRs available. The DNA real-time PCR, which is the commercial names are MycoSure, MycoReal, which it detects both Mycobacterium tuberculosis, but it also detects non-tubercular Mycobacterium. So there can be a confusion. Multiplex PCR is more specific for Mycobacterium tuberculosis because it targets IS6110 and protein B antigen, and hence it detects only Mycobacterium tuberculosis complex. In India, protein B antigen is more commonly seen rather than IS6110. The single tube nested RT-PCR actually looks for RNA for live bacilli, and hence it is also very specific for tuberculosis, and it can give you more information about the disease. Ampiclor is also a RNA PCR, but usually it is not done in genital Koch cases. It is usually done in smear negative pulmonary Koch patients. So now let's talk about GeneXpert, which is also a DNA-based PCR, but it is a semi-automated cartridge-based test to detect Mycobacterium tuberculosis. At the same time, the resistance to drug rifampicin. And rifampicin resistance is a proxy for knowing multi-drug resistance. Now, with the increase of multi-drug resistance, especially in the urban areas, and with HIV-associated TB, which has been increasing, its incidence has been increasing. This GeneXpert test has been endorsed by WHO as an initial test for all adults and children in need for TB evaluation. It is more sensitive and more specific test from all the tests that we have discussed, but it has its limitations as well. It requires it requires calibrations. The electricity supply should be absolutely regular, and it also has its pitfalls and limitations. This lovely study by Dr. Sanjay Singh Negi et al. They tested 172 samples for process for detection of Mycobacterium tuberculosis by ZN staining, smear, LJ culture, BACTEC, which is a radiometric test, and PCR test, amplifying the 1S6110 sequence. And what they found is that the highest sensitivity was found with PCR testing, almost to the tune of 83%. It was 35.2% for smear, 47.16% for LJ media, and 53.45% for BACTEC culture. So, in another study, very elegant study by Dr. Nalini Mahajan et al. In Human Reproduction 2017, very recently, she also compared the various diagnostic methods for diagnosing TB and found that DNA TB PCR assay has a sensitivity of almost 72 to 78.3%. It is very specific for tuberculosis that if the report comes as TB positive, you can be sure that it is TB, but it has false negative rate because of its low sensitivity. It has a false negative rate of 3 to 20%, which means it can miss the diagnosis of tuberculosis in almost 20% of the cases. In her study, she also correlated the DNA PCR with the culture, and she found that there was DNA PCR correlation in 68% of the cases only. IGRA, which I'm going to discuss, which is a test for latent tuberculosis, correlated with culture in 48% of the cases. So you can see that even DNA TB-PCR is not 100%, it's not 100% sensitive. In 3 to 20% of the cases, you can still get a false negative report. Or you can even get a false positive report also, especially if there are contaminants in your lab, in the lab in which it is being processed, and also that it can there can be you could be missing the site from where the biopsy has been taken, because it is said that it's a Cornwall region actually from which the biopsy should be taken ideally. And moreover, there are certain DNA PCR inhibitors like blood. So if your specimen has a lot of blood in the along with the specimen, they act as inhibitors and also contribute to the false negative rate for DNA PCR. So menstrual blood for AFP smear and culture, which has been which actually gained a little popularity, but I think it should be not used for diagnosing TB because it can easily miss the endometrium. The endometrium can be easily missed because of the possibacilline in nature, and moreover, the specimen that you are getting might not be the right sample. It might not be the representative sample. It has to be transferred to the lab or kept in the refrigerator, and this is where the lag happens. And even other AFBs like atypical mycobacterium can also be confused with mycobacterium tuberculosis by this test. So it has a high false negative rate, and hence, according to me, it should not be used for detecting tuberculosis, because once a report of tuberculosis as negative comes to the patient, it becomes very difficult for as a clinician to convince the patient that she could be harboring tuberculosis. An easy way to remember how long each test takes to for the report to come, it's remember the rule of two. The gene expert report will give you a report in 2 hours. Line probe assays, which is usually not done, the Haynes test, which is a second line of test done in for drug sensitivity. The report is available in 2 days. Liquid culture take 2 weeks, and solid culture say take 2 months. So nowadays the focus is more on gene expert and liquid culture as a definitive diagnosis of tuberculosis. The conventional methods diagnose only 15 to 23% cases of female genital tract tuberculosis, with AFB staining having a 10% detection rate requiring 10,000 bacilli, LJ media having 2 to 24% of detection rate requiring 10 to 100 bacilli per ml. Histopathology with granuloma formation has a detection rate of almost the same 3 to 20%, and DNA PCR and gene expert require just 1 to 5 bacilli, almost with 58% detection rate. Now let's discuss the latent tuberculosis. As I said in the beginning of my talk, that mostly actually the world over it's latent tuberculosis, and only 5 to 10% become active tuberculosis. So there should be some tests to detect latent tuberculosis, especially when it comes to infertility, because latent tuberculosis can also get reactivated and become active tuberculosis and cause infertility. So latent tuberculosis cannot be ignored when it comes to infertility. There are 2 tests to detect that. The tuberculin skin test, also called the Montu test, which has been there for a very, very long time. It uses the purified protein derivative, and both these tests measure actually the cell-mediated response, the host and the host response to the bacilli. The interferon gamma release assays, which are in the commercial names, are TB platinum, TB spot, TB gold. Actually, they're not gold standards for diagnosing TB. So the TB gold word actually is a misnomer, because it gives an impression that this must be the ultimate test for diagnosing tuberculosis, which is not so. These tests only detect latent tuberculosis. And we have no test which can predict which patient will convert from latent tuberculosis to active tuberculosis. Since our country is endemic for tuberculosis, they have poor specificity in high burden country like ours for active tuberculosis. And sometimes the cell mediated response may be mitigated because of malnutrition, advanced disease, HIV. It may be blunted because of this, and you might get a false negative results. The WHO recommend that the tuberculin, the Montu, should be preferred instead of IGRA in poor resource settings like our country. This tuberculin test is done by exposing the skin to an antigen, the purified protein antigen, and the dose and is actually also has been not titrated perfectly till today. It has a sensitivity of only 55%, but it is more specific for tuberculosis, which means it has low false it is more specific for tuberculosis and not so sensitive. So there can be false negative. The advantages are it's simple, it's easy to administer, inexpensive. The disadvantages are it requires refrigeration. The patient needs to come back after 48 to 72 hours. You need people to administer the dose, and it is only it cannot distinguish between active tuberculosis and latent tuberculosis. And BCG injection and non-tubercular mycobacterium can also interfere with it and also show a positive response. So you cannot distinguish whether this reaction that you see on tuberculin test is because of tuberculosis or it is because of non-tubercular mycobacterium. That way, interferon gamma release assays, it has an edge over MON2 test. The white blood cells from when they get infected with mycobacterium tuberculosis, they release interferon gamma, which is then measured in this particular test. And it is also measures the cell-mediated immunity. And because of blunted immunity in patients of HIV, malnutrition, advanced disease, immunosuppression, the IGRA response may be very, very blunted, giving rise to a false negative report. Or even if the report comes as positive, by the time the patient comes to you, the IGRAs may be washed away and it might not be able to detect tuberculosis. So the disadvantages are it's expensive, the blood should be processed quickly, errors arise while the blood is being processed and while the report is being made. So there could be lab errors. There is limited data on its use in children and in patients with HIV, but definitely it can be used to monitor the progression of disease, because if it is negative in the beginning and after 3 months, if you repeat and the IGRAs come as positive, you know you are dealing with tuberculosis. You are alerted to the disease so that you can work on the other ways of detecting tuberculosis. Another advantage of interferon gamma release assays is that it is not interfered by BCG injections and it does not detect even non-tubercular mycobacterium. So it does not cause a false positive because of these two things. The results come very quickly and it's a one-time test. It's a blood test. TB Sure also is a fourth generation of IGRA test. It is called the fourth generation test, IGRA test, because it actually measures both. It measures CD4 counts and it also measures CD8 cells count. And what it implies is that the CD4 cell count helps in knowing whether the patient has latent tuberculosis, whereas cells, when the bacteria infection is active, it also secretes CD8 cells, and its detection will let you know whether it is active tuberculosis. So it has 4 tubes where they measure CD4 count, CD8 count. Nil tube is just a control, and the nitrogen tube is to show that this patient has some cell-mediated response is positive or not. So this is a fourth generation of an IGRA test. And according to the review of literature, it helps in distinguishing by these two cells, the count of CD4 and CD8. You can know whether the patient has active tuberculosis or not. But as I said, that it's very difficult for these tests to tell you which patient is latent tuberculosis and which is active tuberculosis. And by the time the patient comes to us, maybe her CD8 count has come down because the patient has not reported immediately to you, and it can be washed out, and so it can give you a false negative report. So if the tuberculin test and the IGRA test comes as negative, you cannot really say that this patient is not infected. A negative test does not exclude the diagnosis of tuberculosis. A positive test just tells you that this patient has been exposed to tuberculosis, and in our country where we are endemic for tuberculosis, exposure to tuberculosis is quite common. So MON2 test up to 15 millimeters actually doesn't even make any difference in our country where we are endemic for tuberculosis. Now, as an infertility specialist, I think I would really say that hysterosalpingography is a very important tool for diagnosing tubal factor infertility. As as we just said, that genital Koch is almost 100% fallopian tube involvement. So this test will let you know whether how the tubes are, whether the patient has tubal factor infertility, and you can plan your treatment in the same way. The HSG has a high validity. If the result is negative, then you can really be sure that this patient doesn't have tubal factor infertility. Whereas in laparoscopy correlates with HSG in almost 78 to 85% of the cases, what we have seen in our clinical practice and also in the review of literature. So in this HSG film, you can see this patient has beaded tubes. She has a left-sided block tube as well as she has beaded tubes. And there is no spill on either of the sides. A lot of description of the tubes has been made, like pipe stem appearance of the tubes, when the tubes appear very rigid, as you can see with total block. Septate appearance of the cavity, and this is a very poor cavity, as you can see, almost T-shaped cavity with irregular outlines, and also there must be intrauterine synecdoche here with blocked tubes. And these are patients who have both a tubal involvement as well as endometrial involvement and fare very poorly even with IVF. Salpingitis ischemica nodosa. I'm going to show you a laparoscopic film of this. You can see the block and the haze. You can see a haze around the corneal end, and this is salpingitis ischemica nodosa when the dye is going into the interstitial portion of the tube. The golf club appearance, again to show a T-shaped cavity with blocked tubes, and this is how it appears, a very poor actually presentation of advanced tuberculosis. Glove finger appearance, another very poor cavitary tuberculosis, endometrial involvement of tuberculosis, and these patients really fare very poorly. Another very interesting is the intravasation or the extravasation of dye, which is very commonly seen in tuberculosis patient. So whenever an HSG, see in active tuberculosis, you should not be doing an HSG. But when it is not active tuberculosis, then very clearly, sometimes you come across this appearance, which is pathognomic of tuberculosis. I included this video to show you how a thin endometrium appears on ultrasound, and even a 2D ultrasound can give you quite a bit of an information, because in the proliferative phase, when she should be having a good endometrium, this patient showed a very poor endometrium. A 3D ultrasound will clarify so many of your problems when it comes to cavitary lesions of tuberculosis, like intrauterine synecdoche, irregular cavity, or they could be adhesions, and all this can be picked up by 3D ultrasound. The laparoscopic findings which indicate that patient could be tubercular, and this is really very important when you're dealing with any patient who has some problem and needs an anatomical correction of the tubal factor infertility, would be a candidate for laparoscopic surgery. And what we see in laparoscopic findings are adhesions, pelvic congestion. You can see tubercles all over the genital tract and even on the peritoneum and in the peritoneal cavity. It is very, very suggestive, very specific for tuberculosis. Frozen pelvis, edematous inflamed tubes, beaded tubes, steomasses, straw-colored fluid in the pouch of Douglas, and caseous nodules. These are some of the very important presentations of tuberculosis. Dr. J.B. Sharma has done a lot of work on tuberculosis, and he does mention Sharma's blue python sign, Sharma's kissing fallopian tube sign when the femoral end of the tube is blocked, calcified tubes appearing as dried skin, tree branch sign. Fitzhugh-Curtis syndrome is very commonly seen in our country in tuberculosis patient. And hanging gallbladder because of these perihepatic adhesions are seen almost in 48% of cases of female genital tract tuberculosis. Colonic adhesions at the junction of the lower two-thirds and upper one-third of the ascending colon is also quite suggestive of genital Koch. So, uh, tubercular peritonitis can appear as a plastic variety, which is or the serous variety. The serous variety is has very a lot of constitutional symptoms like fever, weight loss, anorexia, and more commonly ascites. And plastic variety is the advanced variety when there are adhesions, when adhesions form in the abdominal cavity, and when in this variety it is a doughy palpation of the abdomen, and sometimes you can even feel the tender abdominal masses. So some of the videos I'm going to show you now of all some of our patients who had active tuberculosis were treated and then taken up for IVF. So this is a patient who had tubercular caseating nodules. You can see very clearly this is a caseating nodule which is so nicely visible on the right side. And you can see the tubes have also been affected by tuberculosis. There is thickening of the tubes, and the normal anatomy of the tubes has been, it's almost like a rigid kind of a tube here. Another view of the same caseous nodule. This is plastic tubercular peritoneal peritonitis, adhesions that form, and this is suggestive of advanced tuberculosis. You can see mental adhesions, you can see adhesions between the anterior UV fold of peritoneum. You can see the adhesions here, you can see the urinary bladder here, you can see the thickened tubes, just see the appreciate the thickened hydrosalpingo like tubes, and the endometrium is also looking quite poor with intrauterine adhesions grade 1. So this is another variety, tubercular malignancy as it is called. It's not malignancy, but sometimes the whole peritoneum and the genital tract and all the peritoneal surfaces become studded with these small nodules all over, and this almost is called a tubercular malignancy. It looks like almost like metastasis. This is an interesting video of a patient. You can see very soon how caseation necrosis, which is again a form of very advanced tuberculosis, how it appears. You can see the this side, it's the right-sided, the whole tube and is inflamed. You can see, appreciate with petechial hemorrhages, swollen tubes, and as we are we are doing a salpingectomy, the caseous necrosis, almost like toothpaste coming out from the tubes, is coming out from the femoral end. This is what I was saying. This is salpingitis ischemica nodosa. You can see, can you appreciate how the condylar ends have become so swollen, almost with a bluish hue, and appreciate how the tube has become beaded. And you can appreciate the left-sided hydrosalpinx, whereas when pressing the tube, you can appreciate the dye is coming out when we are pressing the tube. And this is how the hysteroscopy looks like with intrauterine adhesions and a shaggy cavity. Another patient with hydrosalpinx of the right side, you can appreciate that this tube has been destroyed. Normally, the tubal affection of tuberculosis is normally salpingitis, and sometimes, especially in patients of abdominal Koch, it could be exosalpingitis as well, which means there could be serous tubercles like all over the tubes. This is another case with lot of adhesions, you can see. And actually, this turned out to be an ectopic pregnancy. And this is also one of the presentation of tuberculosis, because when the tubal damage happens, then these patients are almost very highly prone to having ectopic pregnancy as well. So on hysteroscopy, sometimes if the tubal correction is not required and the tubes apparently look normal, then you can just go ahead with hysteroscopy. And there are certain signs which you can see of tuberculosis on hysteroscopy as well, like an irregular uterine cavity, intrauterine adhesions, scanty endometrium, pale endometrium, endometrial calcification, caseation not commonly seen, but microcalcifications are quite commonly seen in hysteroscopy. Deep set ostia with hyperemia of the ostia with periosteal fibrosis, fundal fibrosis. You can see certain adhesions at the fundus, very flimsy adhesion that is also suggestive of tuberculosis. Rarely you can see caseous material coming out of ostia, and pinpoint ostia, blocked ostia are also suggestive of tuberculosis. These are some of the films that I've included of to show you how this appears like. You can see some flimsy adhesions here. You can see a deep set ostia, and there are adhesions out here as well. And so with hysteroscopy, we always do a gene expert and bacterial culture along with this to see and have a definitive diagnosis of tuberculosis. So this is a shaggy endometrium. And always when you're doing a hysteroscopy, while you're coming out also, just visualize this is quite a long cervical canal. So it could be a T-shaped cavity as well. So when you're taking out your scope, always keep your camera on so that you can visualize. This is another patient who has adhesions, intrauterine synecdoche, and we are using scissors to cut these hysteroscopically. Very, very rewarding results if you can give a clean cavity to the patient at the end of the surgery and follow it up by ATT. These patients stand a good chance after that. Now, let's come to the treatment. The treatment is, we all know, 4 drugs in the first 2 months. It's for 6 months, and maintenance therapy, which is now of 3 drugs now for next 4 months. These are the various doses. The dots, which is a directly observed treatment short course, also now is to be given daily and not on alternate days. There are alternate ATT treatment as well, like levoflox. If the patients, especially in our country, the patients are INH resistant or rifampicin resistant, and in conjunction with a physician, you can plan out an alternative ATT in the form of levoflox, moxiflox, linzeolide, cyclosporin, clofazimine, and bedaquiline and delmanide are newer drugs. Now, injectables are not usually given even for MDR tuberculosis. There is a shift towards oral medicines for even alternate TB. TB treatment can cause hepatonephrotoxicity, as we are all aware of. Rifampicin and INH, as well as pyrazinamide, have side effects like nausea, vomiting, muscles and joint pains, dizziness, bloody urine, vision changes, fast pulse, numbness, and even a rash, especially with INH. Bruising is also seen with INH. And ethambutol, if the patient starts having vision problems, you have to stop ethambutol. So some of the toxicities can happen. So after starting every month, you should get the hepatic enzymes done for these patients. And after 6 months are over, then every 3 monthly for next 6 months, you should get the liver enzymes done. So when it is active TB and you have a definitive diagnosis of tuberculosis in the form of culture positive, histopathology diagnosis, or ZN staining positive, it is clear cut. You have to give TB treatment for 6 months. You can do a culture after 3 months of treatment, and a drug sensitivity, if it has not been done initially, it can be repeated again. It can be done after 3 months. So these cases are, but sometimes it is not so clear whether it is active TB or not. So in that situation, what do you do? In patients with unexplained infertility, where only the TB PCR has come as positive, should you give them ATT or not? So normally the decision lies with the physician, but the protocol is that you can, if she's IGRA negative, you can repeat the IGRA after 3 months, and you can also do a repeat TB PCR with gene expert after 3 months. And if she is positive, if initially she was positive for DNA PCR, and again she's positive for DNA PCR, especially if you do the gene expert, and her IGRA also, which was negative initially, converts into IGRA positive now, it means she requires ATT treatment. And in patients who have both IGRA and TB positive for DNA PCR, you can offer them. So it has to be a whole picture. You have to take a whole picture. You have to take her clinical history. You have to look at her ultrasound. You have to see her HSG, and you have to see her diagnostic test. Both the definitive ones, if the definitive ones are positive, you are sure you're dealing with tuberculosis. But if they are not, then you combine all these tests to get a comprehensive picture, and then it becomes ground for starting ATT. ATT should not be started empirically. ATT has become a notifiable disease. So, in order to decrease over treatment of over using of TB as empirically, because it is leading to a lot of multi-drug resistance. The incidence of multi-drug resistance is almost 17% in patients who have been treated for tuberculosis. So you have to be careful when you start, and you have to have some ground before you start tuberculosis treatment. In patients with tubal factor infertility, Asherman syndrome, frozen pelvis, TB can, but if the other tests are coming as negative, because this is all plastic healed tuberculosis, as you can say, latent tuberculosis also it can be called, but according to me, these patients should also be treated because they can get reactivated, and most of these patients actually have a very long standing infertility. So if you get findings like this on laparoscopy, it is a ground for giving ATT. IGRAs are helpful in such circumstances because IGRA test will let you know whether this you are dealing with tuberculosis, because sometimes these additions can also be because of non-tubercular um, mycobacterium, or because of previous surgical interventions you could have such additions. But if the IGRA comes as positive in such a case, you are sure that you are dealing with tuberculosis. If the patient becomes pregnant while she is on ATT, IGRA should be repeated after 8 to 12 weeks, because as we know that pregnancy is an altered immunity state, and hence sometimes TB can play havoc or can get activated. And do not stop your treatment of ATT. If the patient is on ATT and gets pregnant, please do not stop your ATT course, because she is more at risk for abortion than a normal patient. And otherwise the pregnancy goes absolutely unnoticed. It's a very smooth sailing for most of the patients, but these patients, especially where there have been endometrial involvement, they have an increased risk of PIH, of placental issues. They have small for gestational babies can also be have also been reported. So you have to give them a regular antenatal visits, and fetal surveillance should be done in these patients. Every diagnosed case of TB should now be notified with the Ministry of Health and Family Welfare, again under the Nikshay Poshan Yojana. So I would like to end my talk by saying that tuberculosis is endemic in our country. We are the TB capital of the world, just like the diabetic. We are the diabetic capital of the world, unfortunately. with a 19, almost 19 to 20% incidence of tuberculosis in patients of reproductive age group, and a big chunk of these patients with tubal factor infertility in our country actually have tuberculosis as the cause for it. It is an elusive disease which is underdiagnosed as it is asymptomatic, especially in the early stages, and hence a high degree of suspicion needs to be maintained. Hysterosalpingography is a very important tool for diagnosing both tubal blocks as well as the cavity lesions. Conventional methods like routine test, MON2 test, AFP culture, histopathology can diagnose only 15 to 23% cases of female genital tract tuberculosis. Menstrual blood for TB PCR is not a reliable test for for diagnosing TB bacilli because of its paucibacillary nature and insufficient sampling. Endometrial biopsy for TB PCR alone cannot be used for starting ATT. So you have to have, as I just said, a combination of tests before you can start TB treatment. The empirical way of starting tuberculosis is not practiced anymore. Quantiferon, TB Gold, and MON2 are used for diagnosing latent tuberculosis. ATT should be given for 6 months, and now the dots favored by WHO to prevent MDR, actually they recommend a daily therapy. So I would just like to speak my experience, our experience, as I just said, that we have a long series of patients of tuberculosis who have achieved success when they were treated early during their disease. They could get pregnant on their own also, or with after laparoscopy, hysteroscopy, and only in those patients who had really severe tubal disease that we had to do an IVF for such patients. We found an incidence of almost 20 to 30% in all our infertile patients in the reproductive age group had tuberculosis. And a HSG, a abnormal HSG or a MON2 test positive alerts us to the diagnosis that if this patient could be tubercular. Then a diagnostic hysteroscopy is then offered to these patients along with TB testing, smear, bacterial culture, TB PCR, and nowadays we are offering Gene Expert to these patients, especially to those who show tubal factor infertility or who show thin endometrium on ultrasound. A laparoscopy is added to hysteroscopy if we think that this patient requires anatomical correction. Then definitely a laparoscopy is also done. Quantiferon, TB Gold, TB Sure are done. If the MON2 test is indeterminate, that is, it is less than 15 millimeters, then I do go for TB Sure and IGRA test. TB treatment is offered if these tests are positive, along with laparoscopy, hysteroscopy suggestive of tuberculosis. Clipping and excision or drainage of hydrosalping or delinking of hydrosalping is offered prior to IVF or ICSI. At least 6 months of ATT is given before taking these patients for IVF ICSI cycles. ATT is continued if the patient becomes pregnant while on ATT. We've had a very good success rate of almost 35 to 45% in patients who are treated early for female genital tract tuberculosis. But the success rate decreases dramatically in patients who have endometrial involvement in the form of synecdoche, adhesions, Asherman's, pale cavity, shaggy endometrium. These patients, we definitely have a lower pregnancy rate. It's the ovarian reserves as well as the endometrial receptivity, which is affected both in, especially in advanced female genital tract tuberculosis, and ovum pickup and embryo transfer can pose a challenge in some of these patients of FGTB. So with this, I come to an end. We have the future of Genital Koch would be in using stem cell therapy in patients with thin endometrium, or injecting subhystoscopic myometrial injection of PRP, platelet-rich plasma, in patients with thin endometrium, or in patients with Asherman syndrome. This is where future of treatment is going to take us. I'll just complete my case history as well.
Yeah.
Yeah. So this is a very interesting case which I decided to include in my presentation today. This patient, Sonam Chaudhary, 31 years, married for 5 years. She came to me with secondary infertility and history of 3 abortions. So she was both secondary infertility as well as bad obstetric history. All were early abortions in the years that I mentioned, September 2017 and January 2018, June 2018. Her menstrual history was quite regular. Her investigations were all almost normal, except a little bit of LH hypersecretion, as you can see on day 2. Her HST showed blocked tubes. She had bilateral cornual blocks. Her IGRA test was negative. Her semen analysis was also negative. So we decided to do a laparohysteroscopy since she wanted her tubes to be opened up, and we did manage to open her cornual blocks. 1 or 2, 3 or 4 drill holes were made for her polycystic ovaries as well, and on hysteroscopy she had a normal cavity. This is how the hysteroscopy looked like, laparohysteroscopy looked like, and both bilateral patency was achieved in this patient. She conceived in the very first cycle with gonadotrophin, 75 international units. And as you can see in my follicular monitoring, which I do on my own, that she conceived in the very first cycle. Since she was very keen for having an early conception, she was offered an IUI cycle. And this is, she just delivered a week back with us, and a healthy baby girl, 2.6 kg in weight by cesarean section. So TB in our country can present with abortions as well. I'm sure a lot of you who are dealing with a lot of tuberculosis would know that it can cause repeated abortions as well. So I thank you all for a very patient hearing. And at the end of the talk, we will have the question answer session. Thank you so much.
So thank you very much, ma'am, for
Yeah.
such a nice and contentful presentation. We highly appreciate. We have a number of questions on the board, but after finishing Jindal sir's presentation,
Yeah.
we will address it one by one. So let me take an honor to take on board our Guru on this auspicious day of Guru Purnima, Dr. Jindal sir. Dr. Jindal sir, of course, he needs no introduction, but he will put his perspective on the topic from the another angle. So let me take an honor to introduce him first on board, sir. Dr. Jindal is a chief consultant and laparoscopic surgeon and andrologist and reproductive medicine specialist of Jindal Hospital. He is a scientific director of Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut. Dr. Jindal is a vice chairman of Delhi ISAR and Delhi IAGE. Of course, he is known for academic excellence, received gold medal of Best Postgraduate MAMC New Delhi. He has over 250 awards from different organizations for his contribution. His contribution is in genetic male giving birth to twins, 5 TESA ICSI babies born together. He has handled series of patients of TESA and micro-TESA ICSI. He has 2 major ongoing clinical studies in andrology currently. He has several publications and presentations, written chapters in 8 textbooks on infertility. And of course, he is a known face for over 200 national and international presentations. He had special interest in fertility enhancing and gynecological laparoscopic surgery. He has special interest also in reproductive surgery, endolaparoscopic and microscopic andrology surgery. He has also achieved a special interest in medical and laboratory andrology. And to me, he is a good orator and singer by passion. So let me take an honor to introduce and on board, sir, our Guru. Please welcome on the stage, sir, Dr. Jindal, sir. Over to you, sir.
Thank you very much. Thank you very much for 2 reasons. Number one, It's a very auspicious day where I thank all the people who have taught me. In fact, I would have never been what I am if it were not for so many teachers who have contributed in their own ways, starting from the teacher who taught me in nursery. So thank you very much for being here today on the auspicious day that I can thank in front of all of you, all those people who have taught me.
Yeah, good day, sir.
And today, I have just wanted to bring in, though it's a very long topic, semen infections. But since Dr. Anshu was talking about today about the genital tuberculosis, I wanted to just bring in very shortly the fact that if a woman becomes infected with tuberculosis and there is a relationship with her husband for a long time, what happens to the man? Will the man get infected or he won't get infected? The problem is if he gets infected and we have given ATT to the woman, she still has a source of infection or not from the husband who is infected. One. Number two, if it is so difficult to diagnose women genital TB, it's an enigma. You don't know what to do. Should you overdiagnose? Should you underdiagnose? What tests to do? For how many months to give ATT? How to give ATT? Are you over giving ATT? Are you under giving ATT? How to give it? There is also one major issue, and the issue is, what do I do if the woman has TB? Will the man be having TB or not? How do I diagnose it? And this is very important because in our own experience, we have found a lot of men who have been infected by tuberculosis. It's very difficult to say whether the man was infected before or the woman was infected before. I mean, you just don't know whether the egg was before or the chicken was before. But the truth is that this disease needs to be understood on a whole. So this is what I would like to highlight and bring to you. Since at our center we do a lot of male work, infective work, and a lot of infections we see, I have in a very short presentation tried to bring you the salient points for you to understand. So I'd like to share my presentation to you at the moment. And it's male infertility and tuberculosis. Now, one thing for us to understand is there are a lot of questions which we have. But do infections lead to infertility? What are the factors of infection which lead to infertility? How does it cause infertility? And I would like to answer a few questions about tuberculosis the way I understand it. There is one thing for us to get. When we look into international literature, there is no international literature because internationally, a lot of countries don't have tuberculosis. I remember it was about 14 years back. I met Dr. Salim Daya, a very famous IVF specialist of Canada. And I asked him a question. Sir, what do you do in male genital tuberculosis? And he said, I have never seen a patient. You are the one who needs to tell me. And I got it right away. That this is an area which we as Indians need to understand and study. So let's understand, out of all the male infertility, 9% is because of seminal infections. Now, infections leading to infertility, they can be infections which could lead to a testicular involvement, leading to orchitis and decrease in spermatogenesis. One. They can lead to male accessory gland infections in the epididymis, prostate, seminal vesicle, urethral glands, leading to obstruction, altered secretory function, and release of inflammatory mediators, which in turn lead to oxidation, DNA fragmentation, and poor fertility. You could have systemic infections, which would impair hormones, testicular function, and spermatogenesis. So infections don't only function in a fashion that a small part is affected, it affects nearly every area of the sperm, starting from spermatogenesis till the time it is released. Now, what are bacteria? Now, it's very short way. I'll just talk about bacteria because till I talk about it, I cannot complete the whole picture. So bacteria, they decrease the antioxidant capacity. Bacteria, because of bacteria, these sperms stick together. They decrease cytokines. They detach acrosomes, lead to defects in the sperm DNA and the sperm. And there are a lot of, normally what affects is gonorrhea, chlamydia, treponema pallidum, and mycoplasma. But also affecting along with that in our country is mycobacteria, tuberculosis, and also the atypical mycobacteria. Now, if you look at the prevalence, the most common bacteria are Escherichia coli, gonorrhea, trachomatis, urolyticum hominis. And you also have a lot of viruses, protozoa, but the prevalence of all of them is mainly in the epididymis, prostate, seminal vesicle. And bacteria and viruses lead at times to what we know as idiopathic male infertility. So what all do infections do? They lead to a problem in the sperm production, abnormal spermatogenesis. There is tubercular orchitis. It leads to bad spermatogenesis. It leads to blockage in the tubes, blockage in the epididymis. So many people who have severe epididymo-orchitis, which is tubercular in origin, are azoospermic because of blockage. You could have everything fine, but prostatic tuberculosis, it would lead to blockage of the ejaculatory ducts, and this would lead to aspermia. Now, supposing there is a mild epididymal infection, which could be tubercular or otherwise, it would lead to a problem in the sperm quality. So what's going to happen? You'll have low motility, asthenozoospermia, and high percentage of abnormal sperms, teratozoospermia. And it can also lead to the quantity problem of no sperms or oligospermia. So this is something which I was trying to bring to you, the whole picture of what it exactly does. Now, something which happens is these infections disrupt the blood testes barrier. They change the semen parameters, the morphology, and they actually produce ROS, reactive oxygen species. Now, this is a slide which I wanted to bring to you for you to understand that oxidation and antioxidation takes place at the area of spermatogenesis, at the area of the epididymis, which is most important, and number 3, also in the ejaculated sperm. Now, how? Supposing there is infection which is present as orchitis, it changes the spermatogenesis and also changes the oxidation in that area. Epididymis is the most commonly affected organ. And what will happen? All these sperms which are made, they're going to have an oxidation which will decrease motility, have them premature, have an acrosome reaction, change the DNA fragmentation. So the functional capacity of the sperm goes down. Now, what do we do? So one thing which we always say is pus cells. So pus cells is leukocytospermia. And this normally should be more than 1 10 to the power 6. And it's a marker of reproductive tract inflammation. And what also can happen is it leads to subfertility, motility impairment, morphology impairment, and decreased DNA integrity. But just understand, pus cells per se are greatly confused with round or immature sperm cells in every laboratory. So what you need to get done is a peroxidase test to see if they are round cells or they are leukocytes. This is a test which is very much needed in the diagnosis. Now, why leukocyte reduction is needed? It is needed because in a normal sperm, if the DNA fragmentation is 25%, and if in an abnormal sperm sample it is 34%, it is 39% when it is abnormal with leukocytospermia. So antibiotics can be given, cyclooxygenase inhibitors can be given, antihistamines have been given, antioxidants are given. But I will not go into this because I can talk on the genital, bacterial, and viral infections for hours together. But I'm going to talk about tuberculosis only to give you the salient points for you to understand. The earlier you diagnose, the better. If you diagnose late, there is a less chance for recurrence by chemotherapy as indicated, and it leads to surgery if it is late, which leads to sterility. If you need surgery, then vasovasostomy, vasoepididymostomy have a very poor result in most of these patients. Now, what happens? There is two types of tuberculosis which you could get. You could get one tuberculosis, which is coming via the bloodstream, and one coming via the urine. Now, the most common manifestation of tuberculous prostatitis is when it comes via the bloodstream. And there are calcifications which are found in the prostate. And epididymitis can take place from any kind of a urinary or ascending infection, and it can also take place from the direct extension or the hematogenous route. Now, prostatic involvement I have spoken about. So we need to understand a couple of things. The most important thing which you need to do is, if there is a lady who has tuberculosis diagnosed by you, the man needs to be examined very well, and a prostatic examination needs to be done as well. His history needs to be taken. You need to see whether he has leukocytospermia. Now, I'll talk about this patient, a 25-year-old patient who addressed to our clinic because of primary infertility. His examination was negative for everything. His counts, his semen sample revealed leukocytospermia, but the semen count was normal. There was a high suspicion due to the wife being tuberculosis positive. He was positive in the semen on TB PCR. We got a culture done. It turned out to be positive. We gave him ATT. Leukocytospermia, which was not treated by antibiotics for 2 months, got resolved in the next 2 months. And this couple conceived by IUI. So there are 3 things which we understand by this. There is a high degree of suspicion. There is a high degree of suspicion if, number 1, there is a wife who has tuberculosis diagnosed, if the man has leukocytospermia with it, and along with that, in case on examination you find a positive finding, they need to be diagnosed. Now, epididymitis is very common. It can lead to obstruction, and even if it doesn't lead to obstruction, it can lead to something which is known as a low quality sperm. So we have to be very cautious if we find epididymitis, which we will come to know once we palpate the epididymis, and you would come to know whether there is pain in that or not, any cragginess in that or not, to diagnose it. Now, this is another patient I'll talk to you about. A 38-year-old man with 4 years of infertility, past history of urogenital tuberculosis which had been treated. There was calcification in the seminal vesicles and right epididymis. Diagnosed as obstructive azoospermia, we did a TISA, got pregnant in the first cycle and delivered. Now, I'll talk of the studies which are there. The studies prove that in these patients who have obstructive azoospermia, tubercular, their sperm retrieval is good. And these patients, the quality of the sperm on retrieval is the same as a normal sperm, and the results of a sperm retrieval are good in obstructive azoospermia because of tuberculosis. This was a patient who came to us with aspermia. Aspermia is when there is no sperm, there is no semen output, very low semen output. Now, we diagnosed that he was hypogonadotrophic. We gave him hormones for hypogonadism. But we also realized that he had a blockage at the ejaculatory duct. We did a TURED, but that was not successful. TURED is when you transurethral go and you resect the area of the ejaculatory ducts in the prostate. So we did a PISA of this patient, and in the second cycle, got pregnant. We need to understand that 1/3 of the patients showed comorbidity which were associated with TB of other organs. So you need to diagnose these patients on a whole as well, not only the genital TB. So in summary, I'll just summarize it. You need to diagnose them early. You need to be very suspicious if the wife is infected, and you need to examine every partner. You have to take a history of the partner infection. You need to investigate these patients by doing a leukocytospermia, doing a TB PCR, doing a culture. You need to treat them, and in case they are azoospermic or the sperm quantity is bad, you need to do ART. One thing which we need to understand, antioxidants have a major role in them. So I wanted to get the whole picture to you clear in 15 to 20 minutes, which I think I would be able to. I, in this month, would also be taking one full 1 hour on seminal infections, which is a very interesting topic to me, because a lot of men need treatment which people do not understand. So I would like to bring it to you. And I would thank you at the moment for sparing a Sunday evening to go through tuberculosis for patients. And this is the most interesting thing. We as doctors are so interested in patients that we go ahead even on a Sunday afternoon to learn something for our patients. Thank you very much. Love you all. Appreciate for being here on Sunday. Thank you. Now I would request, I would go ahead with the questions which have been sent, and Dr. Anshu would like to answer the questions which you have. So there will be questions asked and she would answer those questions. So I think that's important that these questions are answered. We'll take some time of yours. In fact, this is the most important part, because the question of the other person answers your question. So I would like to ask you the questions, and the questions are, the first question is by Dr. Ramalakshmi, and she wants to ask, are IGRA gold test ELISA for IgG, IgM still considered relevant for diagnosis of genital?
See, IgG and IgM are no longer used for diagnosis of tuberculosis. They have been banned both by the government of India as well as by WHO. So this test is no longer used for tuberculosis. And IGRA, as I said in my talk, that it helps you in telling whether it is latent tuberculosis. It cannot tell you whether it is which patient will convert from latent to active tuberculosis. But definitely IGRA IGRA is used, can be used for monitoring treatment. For instance, a patient who is come as negative for tuberculosis and you are clinically suspecting, after 3 months you can repeat the IGRA test again, because it takes almost 8 to 12 weeks for the CMI, for the cell mediated immunity to take effect, and hence you can get a positive result after 3 months. And as I said in my talk also, that if the I really do rely on Montu test as well, and if it is highly positive, more than 15 millimeters, it gives us a suspicion that this patient has been exposed to Mycobacterium tuberculosis, which is very common in our country. But if the report is less than between 10 and 15, then you can do an IGRA test to confirm whether this patient has tuberculosis, latent tuberculosis or not. So it is just not one test which you can rely upon, and you have to do a combination of tests in order to know what exactly you're dealing with.
Now, Dr. Sarita Tyagi wants to ask a question. In your opinion, what is the test which is confirmatory for tuberculosis?
Dr. Sarita, there is no single test which can completely confirm the diagnosis of tuberculosis unless your smear comes positive, your bacterial culture is positive, or your DNA PCR gene expert, if it comes as positive, then also you cannot really 100% on the basis of DNA PCR alone, you cannot put the patient on ATT. As I said in my talk, that if the DNA PCR is positive, you have to combine it with clinical history, HSG finding, ultrasound findings, and laparoscopy, histoscopy if you're doing that. And in combination, and I do go for Montu test as well, because if Montu is highly positive, this is also suggestive that patient we are dealing with tubercular patient. So Dr. Sarita, there is no clear one single test for diagnosing tuberculosis. Yes, if the culture is positive or the smear is positive or the histopathology comes as a granuloma, it is suggestive of definitely it is very specific for tuberculosis.
Dr. Narendra Vaghela would like to ask, what should be the specimen for gene expert? Blood or what?
No, in fact, it should be endometrial biopsy and not blood ever, because actually blood is an inhibitor, is a DNA PCR inhibitor, and hence even your endometrial biopsy that you send for TB, it should first be washed with normal saline and then put in a normal saline vial for histopathology, because blood is a PCR inhibitor, and hence never blood, it is to be endometrial biopsy.
I have received a lot of questions over here, and about 10 questions are such that the question is, what is the best method to diagnose genital tuberculosis?
We've already discussed that a little while ago, so I think we will give it a miss.
Yeah. Now the next question is, please recommend what is to be done for atrophic endometrium caused by genital tuberculosis in case the patient doesn't want to get surrogacy. Dr. Jyoti Bandi wants to ask.
Yes, this is a very difficult situation to handle, because on hysteroscopy, such patients show a very pale cavity, very atrophic kind of a picture. Even on hysteroscopy, it's called a ball-looking cavity. And so, definitely, you have to first make a tissue diagnosis of tuberculosis, treat them for tuberculosis, and many of them will respond to your treatment. And along with this, you have to monitor these patients on ultrasound and see how their thin endometrium is faring. Sometimes you do give them estrogens as well, and if there are adhesions, you have to do an adhesiolysis and do a good operative hysteroscopy, and then only a follow-up will tell you whether this patient is responding or not. If the patient shows a good endometrium, they can be taken up for IVF. or whatever the case may be. But if the endometrium doesn't seem to improve, it is a thin endometrium, in spite of all your efforts, you have to take them. You have to, maybe they have to go for adoption if surrogacy is not in their armamentarium.
Dr. Mamta Chabla wants to ask a question. There was a
Yeah.
patient of infertility, hysteroscopy, tubercular, gene expert positive. How many months should genital TB treatment be given to these patients?
6 months is what is recommended for ATT.
There is another question which is asked, and the question is, if TB PCR is positive, what all do we have to correlate it with before we give ATT?
Yes, that's a very good question. You have to correlate with your clinical histories, right from your clinical history to your ultrasound finding, your HSG report, your hysteroscopy findings, laparoscopy findings if you're doing laparoscopy, before you can give them ATT. So it has to be a clinical criteria, as well as one or two lab criteria should be positive before you can before it warrants ATT. Just on the basis of TB PCR alone, you cannot give them TB, because sometimes it can be false positive, and sometimes, as I just discussed in my talk, that it has a sensitivity of 75 to 78% by most of the studies, which means there can be false negative as well. So even if the TB-PCR is negative, if the other parameters are suggestive of tuberculosis, then there is ground, and IGRA will help you in knowing whether you are dealing with which was IGRA, which was negative before and then becomes positive, could suggest tuberculosis, because IGRA is not affected either by BCG or with non-tubercular mycobacterium as well. It is not affected by that.
There is a patient from Dr. Neeta who wants to ask,
Yeah.
in a patient who has received 6 months of ATT,
Yeah.
before you stop, is there any test to be done?
Yes, as we just said that once you start the patient on ATT, ideally you should repeat the test after 3 months. And if the culture sensitivity has not been done, ideally it should be done after 3 months. Though in our clinical scenario, sometimes it's not possible to tell the patient that again she has to undergo a endometrial biopsy, and again at the end of 6 months she has to undergo an endometrial biopsy. The patient will not like it very much. So we tend to avoid at times, but ideally, yes, we should repeat the biopsy after 3 months, and again at the end of 6 months, TB PCR biopsy should be repeated for the patient, or IGRA should be repeated. Though IGRA, if once positive, will remain positive till the end of the treatment. It is not going to change. So actually, if the patient has IGRA positive in the beginning, there's no point repeating it again, because it will still be positive. And TB PCR also, since it detects dead bacilli also, even after ATT, you can get at the end of 6 months, you can get a positive report for TB PCR, because it does detect the dead bacilli as well.
Dr. Anshu, there are a lot of questions on tubal TB. So I'll just combine them together because there are about 12 questions on this. And the gist of the questions is that in patients who have tuberculosis, which has been diagnosed with blocked tubes, what will you do? Will you give them ATT first, or will you do a hysteroscopy, operate on them first? What will be done? What is the method of treating them?
Yes, that's a very nice question, very interesting question. What we do is we do a laparohysteroscopy, and we do a TB PCR biopsy, bacterial culture, smear if it is positive, smear culture, smear also we do. So we don't wait for just we if there is tubal factor infertility and patient requires correction, as can be seen on HSG, then the patient is taken up for laparohysteroscopy, and we've rarely seen flaring up of tuberculosis, which is a risk there involved, that once you do a laparoscopy hysteroscopy, actually you can flare up the infection. But in our clinical practice, we've hardly seen any such cases. So these patients, without wasting their time, should be taken up for tubal correction surgery, and after the tissue diagnosis is made, should be offered ATT according to me.
What percentage? There is a question about 6 questions on atrophic endometrium,
Right.
and they ask, how well is atrophic endometrium correlated with tuberculosis?
Yes, atrophic endometrium, thin endometrium, as I showed you on an ultrasound picture as well, is quite commonly seen. The patient will give you history of hypomenorrhea, oligomenorrhea, even irregular periods. She will give you such a history. Actually, hysteroscopy is the main line for such patients, because you need to do a correction of any intracavitary synecdoche, any kind of thing that you see inside the cavity. You can see microcalcifications, you can see deep set ostia, periosteal hyperemia, and it will also give you an opportunity to take a biopsy for your tissue diagnosis of tuberculosis for bacterial culture. So actually, these endometriums have to be followed up. There is so they will improve while you give them ATT treatment, provided you have just done a good operative hysteroscopy for them. They will improve on your ATT treatment, and Proganova or progestogens can be given to these patients in order to get a good endometrium as well. So actually, time will decide. And the 2 cases that I showed you in my lab, in my presentation, they fared very well after that hysteroscopic surgery, whereas before the surgery they had a thin endometrium or atrophic endometrium, as you're referring to.
Thank you very much, Dr. Anshu. We've had about 1.5 hours of a very, very intense and a lovely session. And thank you so much for the time and the questions which have been there.
Thank you.
And we all would like to thank the lovely audience which we have.
Thank you so much.
So a lot of respect and love to all of you. And goodbye. Have a great evening. Have a lovely Sunday.
Thank you so much. Thank you.